Dr. Andreas Luebke from Germany to deliver his keynote speech. Dr. Luebke?
So, thank you, Dr. Sophia, for this kind introduction. I just will start with a screen sharing that everyone can see the presentation. So I will go. Yeah. Okay. Oops. My screen sharing is deactivated by the host. Thank you. Very well. Thank you. Okay. So I hope everyone can see the screen and hear me clearly. So does everyone see the screen? I think so. Okay. Well, I will just. Welcome everybody to this keynote presentation. I will talk about pleural effusion cytology at the COVID-19 lockdown. And however, in the meantime, we made great progress in the analysis of our data set. So, and therefore, I can provide you a comprehensive review of our whole cytology specimens of our academic center with analysis of sample numbers, composition, and malignancy rates. So, but of course, we will start with the pleural effusions, and I will begin with a brief overview. The first national lockdown due to the coronavirus disease caused significant changes in diagnostic cytopathology. And we wanted to know how the lockdown altered the case numbers, composition, and the malignancy rates. We analyzed the time window of the first 4 weeks of the lockdown, which means from the 9th of March until the 7th of April, which has 22 working days. And we compared it to an equivalent time period from the 11th of March until the 9th of April, which is again 22 working days. So this was not biased by the Easter holidays, which is an important issue at this time point. So the total number of our specimens, see if the point is working. Yes, very well. We received 900. It's moving forward, I do not understand this. Anyway, so we received 906 specimens at the lockdown time compared to 1,320 specimens, which is a reduction of about 30%, which is marked. So the next slide gives an overview about all our specimen types. Dark blue is the compared time window before the lockdown, and green blue is the lockdown time. We cover all major fields of cytopathology as urine, GYN smears, effusions from pleural, Douglas base, abdominal cavity, and we also do lung cytopathology with BAL, lung EVAs, and bronchial brushings, and also fields like thyroid, FNA, lymph nodes, pancreas, breast. So basically, we cover all important diagnostic fields in cytopathology. What you see at first glance on this slide is that we've got a reduction in all categories. And here you see it in the percentages. And this slide highlights the most interesting disciplines. In urine, we've got a very high reduction, about 50%. Lung EBUS is 47% reduced, bronchial brushings also. Salivary glands, the number was very low, so we exclude this from the whole analysis. So those are our 15 diagnostic categories. We've got the effusions, basically also the pleural effusion. This will an issue we will talk in very detail. And to the effusion compartment belongs the Douglas base, the abdominal cavity, and also the pericard. And then we've got urine, we've got thyroid, we've got lymph node FNA, we've got breast, we've got pancreas. And here you see the lung cytology compartment with the bronchial brushing, the EBUS, and the bronchoalveolar lavages. And this group, pap smears, salivary gland, and other, we excluded from the analysis because of the following reasons. The GYN pap smears were biased by sender dynamics. We had some significant changes that we've got senders, they come and they go, and so it's not really comparable if you want to be honest. And the other category is very heterogeneous. We've got smears from the oral mucosa, we've got some esophageal cytologies, we've got intra-articular cytology, we've got catheters, abscesses, so this is not a very well group to detect some malignancy rate. And the salivary gland cytology is just a very, very small number. So anyway, we still got 12 diagnostic groups to analyze, and one of these groups is a pleural, the pleural effusions. So I will focus on this group first of all. All samples were classified to the International System for Reporting Serous Fluid Cytopathology. As you maybe already know, we just introduced this new classification system at our institution. So I think you're well, you well know the 5 categories. So the first category is just non-diagnostic. If you do not see any cells, it's not well when you do any kind of diagnostics. We've got the group negative for malignancy. When you've got a representative specimen, you can say, well, it's truly free of malignancy. And then you got the 2 categories, AUS and SFM, which I will talk about right now, a little bit later. And of course, you've got the malignant category. Well, to me, I think those 2 categories are very rarely used, but when we use them, they help us a lot. Because when we've got low number of cells or suspicious morphologies, and we do not know how to solve it, how to report it, or we do not have any additional methods like immunocytochemistry or an incident or an additional histopathology, those are very helpful. But in practice, if you got a representative effusion, those are 2 categories that you very rarely use. So usually you can manage to determine whether it's malignant or not. Well, for statistical reasons, we corrected the sample numbers in case of multiple specimens from the same patient in a short time window. So this is not biased by multiple cytologies. And here's the breakdown of our pleural effusions. We see that the overall numbers did not differ that much. We have a decrease of about 10% from 110 specimens to 97 specimens. Interesting is the contrast that the malignancy rate increased from 14.6% to 19.2%. Although the proportions did not differ statistically, but we can see some decrease, and this might be an effect of the COVID-19 lockdown. And as I reported just recently, we do not have any categories like non-diagnostic. Usually the effusions are representative, and AUS and SFM are categories that you do very rarely in your diagnostic daily workup. So the first conclusions from the pleural effusions are that the pleural effusion showed an elevated malignancy rate, in contrast to a decrease in specimen number. And the results might reflect that patients of these groups with oncological risk were not significantly affected by the COVID-19 lockdown. And maybe this possibly indicates a more targeted diagnostic workup in favor of a patient, hopefully. So what did we find? This is the tumor spectrum of the pleural effusions. And you see a quite characteristic spectrum for the pleural cavity. We see NSCLC adenocarcinoma, both at lockdown and both before. We see adenocarcinoma of the breast quite frequently. We see esophageal carcinoma. We also see metastasis of ovarian adenocarcinoma in the pleural cavity, which is quite a regular finding. We see lymphoma and, of course, gastric adenocarcinoma. Sometimes it happens that we even can find colorectal adenocarcinoma. And, of course, the lymphoma appears repeatedly. And although it's reported that this is quite a rare event, in this collective, we at least found one poorly differentiated neuroendocrine carcinoma of the lung in our pleural effusions. So this is the statistic, and this is the relation to COVID-19. But I'd like to take you on a journey with case examples from those effusions. And so this would be the first patient. It's a 66-year-old female patient with a strictly one-sided pleural effusion. So I opened an interactive microscopy, and I hope I will be able to launch it. So I try to show you my browser Zoom image with the scan slides. There it is. So I hope you can see this, the shared screen of my scan slides browser. So I will go to the first slide. So this is it. You see a very, very cellular slide. So I will zoom in because this is cytology, so we need to zoom in. So, and here, even from the bird's eye view, you can see a lot of cells which seem to be of one population. So, and in any kind of examination, when you do not know anything about cytology, you panic, but you can say one sentence. You can say, well, I see a very cellular slide, and this is a very cell-rich effusion. So then you at least got one point. So now we go into the higher magnification. And there you see, let's take a region. Oh, yes, this is fine. In this slide, you see a very cellular population of cells that are very uniform. The nuclei are enlarged and the chromatin is coarse. You can see well recognizable nucleoli. Those are also quite large, and the cytoplasm is scant. Those cells do not form clusters or groups or sheets. They are lying single. And just to compare the size, you can take the other usual cell types you find in any effusion. You can find macrophages, like here and here and here. Basically, the macrophages are quite recognizable when you see the intracytoplasmatic small vacuoles. Sometimes they can be indistinguishable from mesothelial cells. For example, this looks more like mesothelial cells. And of course, sometimes the mesothelial cells make small groups. So, but you can clearly see that the nuclear chromatin, for example, of those benign cells is truly different from the tumor cells. So, find some small lymphocytes. Small lymphocytes are something like a reference for your eye sometimes in cytopathology, because you can estimate the size of the nuclei. Although malignancy is not defined by nuclear size, it gives us a hint whether this could be suspicious of a malignancy. And if you compare the standard lymphocyte, for example, this or this, and maybe this, you can see that those cells are thrice, fourth, or five as large as those suspicious cells. And given the discohesive appearance of those cells, of course, this is highly suspicious of lymphoma. So what can we do to further characterize this lymphoma? We can see whether we've got some more information if we are using immunocytochemistry. So I will go to a cytoblock. You might know this technique. Basically, there are two different ways you can do your immunocytochemistry. You can do your immunohistochemistry on slide, so you get smears, and on those smears you do your immunohistochemistry. The trouble is that sometimes the immunohistochemistry doesn't work very well on the slides if there are smears. And if you prepare cytoblocks, the technical performance is much more standardized. So what we do, we take the tumor cells and mix it with agarose and make some small pellet and put this pellet into a paraffin block. And as you might know, you got excellent results in the immunohistochemistry. So this is a sample of those slides. So you see here, so this is the cell block. And then we go deeper into it. There you should be able to see it. And what you truly recognize, this picture is almost the same like in our smears. You see again, highly atypical cells with coarse chromatin, nucleoli, and very scant cytoplasm with a bystander cells of small lymphocytes and macrophages and some mesothelial cells. So basically, what we know is that the cells we would like to investigate further do appear in our cytoblock. This sounds very simple, but this is very important information if, just for the quality control of your cytoblock. So then we go further on and do some immunohistochemistry. So, and this is, so this is CD79A, a usual and broadly used B cell marker. Of course, you can also use CD20 or CD19. Sometimes it depends on your technical performance or your institution. I like to use CD79A because we've got some cleaner staining results. CD20 is very sensitive, but sometimes very brown. So usually we use these markers together. And here we see a clear and remarkable clean positivity of CD79A. So now we know that it's a B cell neoplasm a high-grade B cell neoplasm, and to undermine this, we can do a proliferation marker. So this is Ki67. And you can see that Ki67 marks about 60 to 70 and sometimes 80% of the tumor cells. So this is a highly aggressive B cell neoplasm, and this qualifies for a diffuse large B cell lymphoma. One important thing you have to keep in mind, although it's very rare, you can have primary effusion lymphomas. And those primary effusion lymphomas are associated with HIV infection. So you need to test HHV8 to exclude that it's a primary effusion lymphoma. So this was negative in this particular case. So therefore, this is just a diffuse large B cell lymphoma in the pleural one-sided effusion. So then I will go back to the presentation. I hope this works. So, and again, some images. I prepared those images just in case the technical circumstances were not in favor for the interactive microscopy. So here's again what we've seen before. This is our B cell neoplasm, blastic cells with enlarged nuclei, coarse chromatin, prominent nucleoli, scant cytoplasm, CD97A, and Ki67 very high. So this is diffuse large B cell lymphoma. So the next patient is a 63 years old female patient. She's got a known NSCLC adenocarcinoma. And let's see what cytology tells us. So this is a cytospin of the specimen because the amount of effusion in this case was very low. So sometimes our technicians do the cytospins, although I prefer the smears, but the low volume might have justified this. So let's go into the higher magnification. And even on intermediate magnification, you see that there are clusters of cells which seem to be a second population. And although the scan is a little bit blurred because we have different levels of scanning, and especially, as we all know, cytology is not a two-dimensional diagnostic discipline, it's always three-dimensional. And this implies that we have to alter our focus sometimes, and if you do a scan, you never get all cells on the same level. And that's okay, because we don't want that, because we want a three-dimensional impression, because this gives us more information about the tumor. Anyway, if we go to the side, where the layer is more flat, we can go to a higher magnification. And here, although it's not very sharp, you see there are very large intracytoplasmatic vacuoles. You can even spot them here. And you can see that all those atypical cells form clusters. And I will try to give you some informative areas. So this takes some time, but this also reflects a very important issue of cytopathology. You need to search, you need to screen, you need to be patient, and you need to keep your eyes up. So there's the region I would like to investigate. And I also would like to point out that cytology is a diagnostic procedure where you can get some information even from the bird's eye view. Usually you say, please screen your slides at a 100 magnification. Yes, that is true. But if you take your slide from a bird's eye view, you can also get many informations that might be lost if you just screen it on a very high magnification. And as you can see here in the middle, this one, you can see large cells, a little cluster, and you see the halo. So this is a shrinking artifact of the cells. So in reality, they are more large than that. So when we go into the higher magnification, like this, so let's go to the highest. Yeah, and there you see a small cluster of atypical cells. They've got a large nuclei. Chromatin is inhomogeneous. The cell membrane the membrane of the nucleus is also irregular configured. And you see large intracytoplasmatic vacuoles and large shrinking artifacts. So an NSCLC adenocarcinoma was known, and those cytological characteristics fit very well to an adenocarcinoma. So we did not do any further investigations or immunocytochemistry, and we classified this just as fitting to the known NSCLC adenocarcinoma. So I will go back to the presentation. So this is it. Here you see we found the same cells that I took a photograph from. So those are the cells, prominent nucleoli, enlarged nucleus, prominent intracytoplasmatic vacuoles, classic example of NSCLC adenocarcinoma and a pleural effusion. So the next patient is 71 years old. It's a female patient, and a tumor in the lung is reported. So this is it. Here we've got some interesting scanning artifacts. At the first glance, you see, oh, this is not a very suitable slide to investigate. However, we are just at the beginning of digital pathology. And as we all know, it's easy for the trained pathologist to deal with artifacts, to deal with contaminations, to deal with false positive immunochemistry. And this is the same thing. There will be artifacts in digital pathology, and there will be things as provided as the people who sell you your microscopes, your monitors, your evaluation software. So this is more reality. And therefore, I think we have to also learn to see these artifacts and just to deal with it in our diagnostic workup. Because it's very difficult to argue that you say, I cannot make a diagnosis because of the artifacts. So when the clinicians will say, no, the artifacts are not the problem, you are the problem. So anyway, we take a look in the region where we've got this quite cellular smear. And you can see even at this magnification with the bubble artifacts here, that there are some groups and aggregates of cells at a bloody background. So they at least form clusters. And then we go at a higher magnification. Although there are some stripe artifacts, we can see that those clustering sheets of cells do have an atypical appearance. I will try to search some more informative regions. I think this should be well, let's take this one. Because this is a beautiful cluster and we can have at least some cells in focus. Yes, I think those should do. You see that the chromatin of those cells is smudgy, and we do not deal with very large nuclei. It's difficult to define the borders between the nuclei because the nuclei do something like molding. So, and this is apparent, although sometimes it's not clearly sharp. So we've got clusters of cells with an inhomogeneous chromatin, sometimes with a characteristical salt and pepper appearance, and a quite very well visible nuclear molding. The cytoplasm is very scant. It's very difficult to identify the cytoplasm. And one interesting feature in this particular specimen is that the cells do not seem to be very vulnerable. They are quite stable. And this tumor entity usually has the characteristics that the cells, the nuclei are smudgy, and it's very difficult to identify those clusters. So I will switch to the presentation because I made some distinct photos of this because it's very difficult on live microscopy to show you the characteristic features. So those are the cells. This is a little bit more clearly. And here you see the features I already outlined. Nuclear molding, scant cytoplasm, salt and pepper, chromatin forming small, sometimes a little bit papillary architectured sheets. And here we see some smudgy chromatin and some vulnerable cells like this, but basically the clusters are very intact. So this is the best and highest magnification I can get, which highlights the nuclear molding. So an example of the molding is here. This is also quite clear. So in summary, this is a small cell carcinoma, small cell neuroendocrine carcinoma, which is quite a rare finding in the pleural effusion, although it's a very frequent pulmonary neoplasm. So let's go to another cavity, or a tumor that possibly derives from another cavity. The 70-year-old female patient has a tumor in the abdomen. He's got ascites, and there's a one-sided pleural effusion. And we take a look at this one-sided pleural effusion. So here it is. So the specimen is of intermediate cellularity. And what I said before, even in the bird's eye view, you can identify suspicious clusters of cells, like here. And you can go quite thoroughly to these definite clusters. And even at this low level magnification, you see the papillary architecture of them. Those are the vessels. And here, grape-like, you find the tumor cells. Some shrinking artifacts, which is a very recognizable phenomenon, especially in bloody samples. And then we can go to the highest magnification. And there you see, although it's a bad tumor, it's a beautiful morphology, in my view. We see the axis of the vessels and the grape-like papillary epithelioid tumor cells growing on those vessels. The chromatin is hyperchromatic. It is coarse. You can see small nucleoli, and sometimes you can spot some cytoplasmatic vacuoles. Maybe we are lucky. Well, the vacuoles in this specimen are quite quite small. But you can see that the nuclei have truly got a high-grade atypia with hyperchromatic chromatin and inhomogeneous appearance of the chromatin. And here you find some clear intracytoplasmatic vacuoles. So well, this morphology is quite characteristic for an serous neoplasm of ovarian origin. So this is a woman, she is 75 years old, and you always have to think of the possibility of a metastatic manifestation in the pleural effusion. So what can we do to investigate this further on? As I said before, we do a cytoblock, and let's see if this cytoblock contains the cells we would like to investigate. And here you see, although the number of cells in the effusion is quite low, it's possible to get this into the block. So, and this is a very nice example of a characteristic architecture you've already seen in cytology. So this is a two-dimensional image, and you can clearly identify the papillary architecture of the tumor cells together with the intracytoplasmatic clear vacuoles. So then we can go on with immunohistochemistry. And here you can even spot from the bird's eye view, this is the cluster we would like to investigate. So there it is. And this is a little bit too high. So, and this is a nuclear marker PAX8, which identifies the Müllerian origin. Additionally, you can do another immunohistochemistry for the known P53 mutation. So this is P53, which is very, very frequently mutated in ovarian adenocarcinoma. And here you see the nuclear positivity of P53 in almost all cancer cells. So this is a metastasis of a serous ovarian cancer high grade. So then we can go further on. Those are the clusters we already seen quite well on the slides. And this slide highlights the intracytoplasmatic vacuoles, quite characteristic for a serous carcinoma. And this highlights even more the polymorphic nuclei of this neoplasm, indicating its high-grade nature. So the cytoblock you've already seen, the papillary architecture, and this is PAX8, and here you've got the P53 positivity. Very well, then we go back to our next case. So this is it. 70 years old female patient, breast cancer, several years ago. So in this effusion, you see this structure. And as an experienced cytopathologist, you know that this does not belong into this effusion. So those clusters can be very sparse. As you can see in the whole slide image. So this was the whole slide. And there are only scattered clusters of cells, like here, marked by a skilled technician. So, but even in the intermediate magnification, you can easily spot those ball-like structures. So there you can see this is suspicious. In conventional cytopathology, this is a little problem because even if we get focused as much as we can, it's quite difficult to look through these clusters. They look like ball-like structures with condensed and very narrow nuclei. The cytoplasm is scant to intermediate, but it's quite impossible to further characterize those cells. Therefore, a cytoblock is very helpful. Here you can see the block, and then we go for our cell clusters. Let's see. There is one. So let's look into it. Now the three-dimensional image becomes two-dimensional, which makes it very easy for the pathologist. So this is the tumor cluster, and here accompanying benign cells. So what we did, of course, we need to ensure this diagnosis because the ball-like structures are very suspicious of breast cancer. And here we go. This is GATA3, a transcriptional factor, which is usually positive in breast cancer. But beware, it's also positive on the nuclear level in urothelial cancer. And here we see a clear positivity for GATA3, indicating that this is a breast cancer sample. So this is the image from the cytoblock, as you've already seen. And this is, again, another cluster with positivity of GATA3 in the nuclear level. So next patient is 70 years old male patient, diagnostic workup and suspicion of gastric cancer. Again, you see that the cellular composition is very low in regards of tumor cells. And you have to screen a lot to find those small suspicious aggregates. And although this is a quite small sample, I will illustrate the characteristics. Here we got three groups of cells. Those are mesothelial cells. They've got a broad cytoplasm, which is amphiphilic and more green in this specimen. The nuclei do look quite similar with no significant atypia. Here, you got the other population, which is present in effusions. Those are macrophages. You recognize them with the intracytoplasmatic vacuoles. And of course, usually one inconspicuous nucleolus. And there you see the tumor cells. The cytoplasm is scant. They've got prominent nucleoli, and they make clusters. And this is also compatible with gastric adenocarcinoma. Sometimes it can be difficult to interpret those three-dimensional figures. And then you can rely on additional stains. For example, if you do additional Giemsa stains, you can see that those cells, as we've seen in the interactive microscopy, might be present also at the Giemsa stain. And here you can spot one cyanide ring cells, which is again an argument for a gastric adenocarcinoma. So the next patient is a 64-year-old female patient, metastasizing adenocarcinoma of the rectum. And there you can find, again, atypical clusters with quite sharp borders and hyperchromatic nuclei. It's very difficult to make a definite diagnosis on this image. So additional immunocytochemistry could be helpful. It was possible to get a cytoblock, very few cells, but again, we reached it. And then we did immunocytochemistry, and this was positive for CDX2. So it was possible to make the final final diagnosis of the metastasis of a adenocarcinoma of the rectum and the pleural effusion. So, well, this was a little journey on classical and cytology with the aid of immunocytochemistry. And now I would like to go back and show you some more issues about the cytology at the COVID-19 lockdown. So this is the spectrum. We've seen most of those cancers, but what about the other categories? We had 12 groups to analyze, as you might remember, and we just seen the pleural effusions. So what about the other effusions? So the abdominal cavity remained quite stable results. We only went down from 61 to 57, and the malignancy rates almost stayed the same. So no COVID-19 effect. The tumor spectrum is also quite characteristic. We got ovarian adenocarcinoma and also colorectal adenocarcinoma, pancreatic adenocarcinoma. So this is a quite usual spectrum. I'm sorry that the slides are flipping. I do not know why they are flipping by themselves. I'm not pressing anything. It's weird. Anyway. The Douglas space also was quite stable, but the numbers of the specimen reduced, and the malignancy rate rated up and almost doubled. So this was not statistically significant. However, we see a shift from a reduction of specimens and a rise of malignancy. So, of course, in the Douglas space, we've got ovarian adenocarcinoma, the dominating entity. No other relevant entity we did find in this issue. So the pericardial effusions are more for the sake of completeness, because usually you do not have too many pericardial effusions, but they belong to they belong to the effusions, and therefore we cover this just for the sake of completeness. And if we go to urinary cytology, we found something very interesting. We found tremendous changes in number because we had a reduction of 460 to 221 and a very significant drop of the malignancy rate. So this was a significant finding, and the rate lowered from 3% to 0.0045%. And this is remarkable. And this is the only significant finding we found in our cytology investigations. So now we switch to lung cytology. So those are bronchoalveolar lavages, and they revealed a slight reduction of specimen number. And the notable change in malignancy rate was due to incidental findings, a chronic lymphatic leukemia, and an adenocarcinoma of the lung, well differentiated. A potential bias could be that we do cytology and histology as a combined diagnostics, so that we get the lesion either by cytology or by histology. So this might be a little, oh, excuse me, it jumped again, sorry. In the bronchial brushings, sorry, yeah. So in the bronchial brushings, we got a significant, well, not statistically, but remarkable reduction of the specimen number and a highly increased number of tumor findings. So those were classical squamous cell, non-small cell lung carcinomas. So this is an incidence that was borderline significant. So, and this might be due to the fact that we do cytology and histology as a diagnostic workup for patients with suspicious lung lesions. So this is interesting because this was the only borderline significant finding. Well, the EBUS of the lung also drastically reduced from 28 to 12 at COVID-19 lockdown, and the malignancy rate also dropped down. So this was not statistically significant, but this might speculate that some lesions might be postponed. The tumor spectrum of the lung EBUS was, as to be expected, NSCLC, squamous cell carcinoma, and adenocarcinoma, and a minor proportion of poorly differentiated neuroendocrine carcinoma. Thyroid FNA was one of the stable categories with almost no changes in number and malignancy rate. The tumor spectrum was, as expected, papillary thyroid carcinoma, follicular thyroid carcinoma, and medullary thyroid carcinoma could be identified. The lymph node FNA also reduced the number, but the malignancy rate stayed quite stable. So this had no statistical significance. The tumor spectrum of the FNA was quite broad, but this is due to the nature of the investigation, because we've got multiple locations. So we find squamous cell carcinoma, neuroendocrine carcinoma, breast cancer, pancreatic adenocarcinoma, papillary thyroid, because this is just an inhomogeneous group of lymph nodes of different locations. The pancreas FNA also remained quite stable with basically unchanged numbers and percentages of malignancy. And of course, in the pancreas FNA, we find pancreatic ductal adenocarcinoma, which is not surprising. For the sake of completeness, we have some breast cytology, but we only have cysts and nipple discharge and no malignant cases. As you all know, that the workup for breast cancer is is done by histology and not by cytology, but at least you need to know what a breast cancer on cytology looks like. So this is the summary of all our malignancy rates. We see a drop down from 908 to 519 and an increase of the malignancy rate. And if we exclude the classic screening discipline of urine cytology, where you screen for bladder cancer and you do follow-up for bladder cancer, you find an even more elevated malignancy rate. So this rises up to 15.7% if you took all this together and exclude urine. So, and this is a summary of all the analyses. So we did not find increased malignancy rates that were significant, but we find an increased borderline raising of malignant cytological diagnosis and bronchial brushings. We found a decreased malignancy proportion in urine, which is not surprising as it's screening and follow-up. A little bit increased were the pleural effusion and the Douglas space, and basically unchanged the abdominal thyroid, lymph node, pancreas, and breast cytology. And BAL and EBUS was a little bit decreased compared to the time before. So, and now, what can we conclude from that? So, first of all, it's very easy. The COVID-19 lockdown reduced the overall case numbers in cytology compared to the equivalent period in 2019. At lockdown, the proportion and malignancy rate in urine specimens decreased significantly. Well, and this could be expected in a classic diagnostic screening and follow-up tool with a relatively low risk of serious delay effects. It doesn't play a very important clinical role if you postpone urine cytology just for bladder cancer screening. The findings in lung cytology revealed heterogeneous results. The specimen number in EBUS decreased more than 50%, and also the malignancy rate did decrease. However, those findings were not significant. The borderline significant increase in bronchial brushing could be a possible compensation of that might be because this diagnostic workup is done together. Although this could identify a diagnostic group that might be more vulnerable to the lockdown than other categories. The pleural effusions and samples from the Douglas base showed an elevated malignancy rate in contrast to a decrease in specimen number. And these results might reflect that patients of these groups with oncological risk were not significantly affected by the COVID-19 lockdown. The cytology of the pancreas, thyroid, lymph nodes, and abdominal cavity revealed relatively stable numbers in malignancy. And from this follows that these diagnostic groups were not significantly affected by the COVID lockdown. So in the end, we can summarize that except the classic screening and follow-up, urine cytology, and a questionable decrease in lung EPUS, diagnostic cytopathology remained a very stable tool in our single center analysis. The summarized sample numbers decreased, but the summarized malignancy rates went up, possibly indicating a more targeted diagnostic workup in favor of our patients. And this gives us hope and confidence that we are able to maintain diagnostic patient care even under severe circumstances like the COVID-19 lockdown. Well, and here I come to the end of my presentation. I thank you very much for your attention. And a very special thanks to our resident, Maximilian Lennart, who cared about the technical scanning of the slides. I'm very thankful for that. And yeah, I was happy to share my results with you. Thank you.
Thank you, Dr. Andreas. That was a wonderful presentation. And it just highlighted the vast spectrum of cytology that you have shown for us with beautiful images. And congratulations to you for showing a wonderful spectrum. I would like to now call upon our next